At the outset, I would like to thank the organizers for giving me this opportunity to be with you this afternoon, talking about monitoring coagulation and judicious use of blood and blood products in a setting of massive obstetric hemorrhage. I bring you greetings from my hospital, the Anand Medical College and Hospital that I work. And in the next couple of 20 to 25 odd minutes, I'll be taking you through the parameters that we use to monitor coagulation in a setting of massive obstetric hemorrhage, the role of TEG, and the current concepts regarding blood and blood products. When I was looking at the incidence of DIC in massive obstetric hemorrhage, I came across the recent report coming from CMACE UK, which have shown a sudden drop in their massive obstetric hemorrhage, this being the 6th cause now from the 2nd cause of direct deaths in maternal females in UK. And this is quite contrary to our statistics where we have a high mortality figure. And most of our patients are indeed dying because of massive obstetric hemorrhages. And nearly all these causes of massive obstetric hemorrhage ultimately end up either in the ICU with DIC or any of these complications. The point what I'm going to make up here on this slide is that placenta accreta and percreta are something that we are seeing alarmingly increasing in our country thanks to irrational use of cesarean sections happening right here, left and center, in most of our places. But we have to be bothered about, these are the most common causes that can lead on to torrential bleeds leading on to DIC. And before we go on to look at the coagulation parameters, just have a look at how DIC sets in a picture of massive obstetric hemorrhage. Whenever there is a massive hemorrhage, due to any of those causes that I've talked about, there's a systemic activation of coagulation because there's a massive spill of the tissue factor and procoagulants that are already there in large numbers in the decidual placental interface. And as soon as they spill on into the maternal circulation, there's suddenly a huge activation of the coagulation cascade. And what happens is a lot of consumption of the clotting factors occurring. Rather, in the scenario of obstetric setting, it's different from other settings like trauma, is that this factor, the consumption of clotting factors, takes precedence and actually goes on at enormous rates, enough to cause DIC by itself. However, we also have ongoing losses going on, and then this is compounded by the massive dilution that we do by aggressive resuscitation with the help of crystalloids and colloids, which are known to impair coagulation anyway. And all these factors lead on to a state of coagulopathy, which goes on to a vicious cycle of bleeding again, and this goes on. And as you all are aware, in the scenario of a massive obstetric hemorrhage, there is a huge degree, I would say, of hypoperfusion occurring, acidosis setting in, and hypothermia thanks to the cold fluids we're giving, which further impair the coagulopathy, and this goes on to maybe serious consequences. So hence, we need to look at parameters that can actually find out these diagnose these parameters quite early for us so that we stem the coagulopathy quite early, and also to help us guide the hemostatic therapy. At the same time, we would also like to have some parameters that can help us monitor the massive transfusion that we are doing. And apart from the clinical and the laboratory data, what we are really bothered about is it is a very acute and fast-moving process that is happening in massive obstetric hemorrhage. So what we are trying to look at is some point-of-care monitors that can give us on-site faster reports than your lab results would come in. So there is where this something called HemoQ comes into picture, where it gives you an instant report within less than a minute and tells you what the patient's current hemoglobin would be. The only disadvantage it gives you is that it is invasive and intermittent, so you need to have a decision on when to time out your repeated tests. And that is where the new technology is coming in through. This is a co-oximeter which is non-invasive, and it's a real-time monitor. You can have it on the patient like your pulse oximeter, and it actually can help you make a decision on whether you need more RBC transfusions or not. Moving on to our standard coagulation parameters that help us to diagnose DIC in the form of a prolongation of prothrombin time, your bleeding time, the APTT, FDPs and D-dimers, and a reduction in the fibrogen and platelet counts. We have to remember one thing. They are going to come positive only when our blood loss is something to the magnitude of 1.5 to 2 times the blood volume has actually been lost. They are not going to come out positive before that. Furthermore, there are going to be limitations in interpretation because we have to remember that all these coagulation factors, especially fibrinogen, they rise as a matter of physiological response in pregnancy. So in a normal pregnant patient, you might have a shortening of the PT and the APTT. Now in this patient, if there is DIC setting and you have sent a sample, the prolongation that would come would actually be falling in the normal non-pregnant range of that lab. So you will be interpreting as this patient does not have a DIC, whereas this patient has already moved down to DIC because there is a shift in her parameters. The problem is we do not have normal ranges for pregnant patients. We have ranges for non-pregnant patients, and we are comparing with them. And moreover, we'll need serial assessments mandatorily. Now, these all are confounding factors in this fast-moving scenario. And therefore, if there was a recent review, this is an article which has looked at various tests used in massive obstetric hemorrhage settings. And what they have found is that APTT, PTT, all your standard coagulation parameters, they are less affected by the volume of blood loss. And they have long turnover times. You take around 4 hours for the test report to come back to us. And by that time, your patient would be actually quite moribund by that time. And moreover, they do not measure the acute dynamic changes. You're using the plasma to do it. It's not done in whole blood. You cannot measure the function, platelet function. However, there's one test that they found correlating very well with the increasing volume of hemorrhage, and that's fibrinogen level. And this has been brought out beautifully by an article way back in 2007, where they found that it was an early marker for impending severe PPH. It can actually tell you that there is going to be a severe hemorrhage oncoming to you if the values are falling somewhere between 2 grams per liter. Remember, in pregnancy, the values are something between 4 to 7 grams per liter. So this is a sensitive marker for us. However, we have an advent of a new, it was there initially also, but it's coming back to us in a new way to us because it offers us a real-time point of care testing in that it measures the whole blood and not the plasma. It measures the viscoelastic properties, that is, it measures the entire process of coagulation right from fibrin formation to fibrinolysis. So we can help, it actually can help us target blood component therapy. And we just look at the trace that it gives us, and the information it gives us is that the initial R, that is the time to first fibrin formation, is a function of the clotting factor. So if there is any prolongation up here, you need to replace it with FFP. And this is where, at this point of time, all your conventional tests would stop reading. So nothing is read after this. So we really do not know in a conventional test what is happening after to the clotting process. The most important parameter here is the rate of the clot formation, which is designated by K, or the alpha angle. And if there is a problem coming up there, then it's prolongation coming up there that indicates a deficiency more particularly of fibrinogen, and hence you need to supplement more of cryo and fibrinogen concentrates here. And the third important parameter is the maximal amplitude. That is a function of the platelets, more around 90% contribution of the strength of the clot up here by the platelets. So if there is some deficiency coming up there, you need platelets to be supplemented. And of course, then you can also look at the fibrinolytic activity occurring in DIC and maybe add some antifibrinolytics up there. There is another component, the ROTEM, that's a modification of the TEG, which has a beautiful component, the FIPTIM component, where you're actually putting some platelet inhibitors, stopping the platelets and looking at the contribution of fibrinogen. And there have been studies which are suggesting that using this, we can bring on early, we can find out early how early that there is a deficiency in fibrinogen and use it as a first line of hemostatic therapy. And these are the studies that are a beautiful review article that you can go through, which actually talks about the strengths of TEG in a setting like pregnancy, where they have been shown, they have reviewed studies where they've shown to actually encourage rational use of blood products. So as a whole, you're reducing the amount of blood and blood components and the subsequent complications that come along with them. A step further is a new technique that has come up is rapid thromboelastography, because conventional thromboelastography takes around an hour to come in. So this gives you results within 5 to 15 minutes and actually has been used in war theaters and trauma theaters. We can actually extrapolate it to our obstetric areas as well and maybe have more studies on this section. And what does all my talk take us? Does it mean that we leave aside our conventional test and we go on to only point of care testing? I would like to ask, how many of you in your centers have TEG up there? Only one, even two. Even I don't have a TEG at my place. So, we'll take time to procure, get used to that monitors, because we're not of operator dependence, a lot of skills involved into that. So till that time, we'll have to use the combination of the two. But however, there is a definite shift towards using these techniques to guide us through the hemostatic therapy. Because in the current strategy, the mainstay of any resuscitation in a setting of massive obstetric hemorrhage is hemostatic resuscitation. And one of the most commonly used agents is red cell transfusion. Now, as per our previous guidelines, which say that you can use RBC transfusion whenever there is a hemoglobin level below 7, especially if there are signs coming for inadequate carrying capacity. However, the recent guideline says that you have to target the hemoglobin level at around 8 to 10, because this is a patient who's actively bleeding. The problem with actively bleeding patient is that your hematocrit is falling quite fast down, and there is a disturbance in the hemostasis, because as your hematocrit goes down, the platelets come into the central stream, and they don't go onto the sides of the vessels, and therefore no clot formation occurs. So you need an optimal hematocrit. You need to supplement with RBCs. But at the same time, you have to remember, using only RBCs is going to cause a lot of dilution of clotting factors. And that is where you need to take in your fresh frozen plasma quite early. Though conventionally, what we were taught, and we are still, I hope you all are practicing still, is that we transfuse FFP only when after we have given 4 units of RBCs, or there's a massive loss occurred, or the APTT values come after 4 hours and they tell us they're 1.5 times the normal, right? But the recent studies, they actually advocate early and optimal transfusion. And this shift in this thought has actually come from the war theaters of Iran and Iraq, where they found a decrease in the coagulopathy when they were replacing blood loss in a 1:1 ratio of RBC to FFP. And what we are actually trying to correlate it to obstetric hemorrhage, because the torrential bleeds that occur are almost at par with that. And there has been a recommendation of a acute transfusion package that consists of a ratio of 1:1 of RBCs to FFPs and also platelet concentrates. And the rationale behind is that the circulating blood, whole blood, contains all these elements in a 1:1 ratio. So why do you want to supplement them in some other ratios? We should be supplementing them at the same time. And when they actually did it and they reviewed a few studies up there, they found that it had an evident survival benefit in these particular group of patients. The same holds true for platelets, because though we have been transfusing them when the platelet counts really fell down, we have to remember that in pregnant patients there is already some degree of physiological thrombocytopenia that's get compounded by further hemorrhage and resuscitation. So there is a need for proactive administration of platelets during acute hemorrhage. And though there are no studies in obstetric hemorrhage that I could actually gather, I could find one of the studies in a ruptured aortic aneurysm where they use this proactive transfusion package, 5 units of RBCs and FFP and 2 units. And then what they saw that when these patients arrived in the ICU, their requirements for blood transfusion and the survival rates were quite good. So early aggressive therapies are actually the call of the day today. And the most important element that I come to last is the fibrinogen, which is being now projected as a first-line hemostat, because they have seen that when your levels are falling as close as 1 gram per liter, there is a serious indication of a severe hemorrhage coming on. So you must target to keep your level something above 2. Not only that, you also need fibrinogen if you are going to try out hemostatic therapies like factor 7, which is the talk next to mine. And so you need to really take up your levels to at least to above 2, so that these therapies act for us. And if you just look at this blood clot in an undiluted state, and then this is what it looks like when you dilute it with your colloid and your saline. And they've tried adding fibrinogen and also prothrombin complex concentrate into this, and this is where you get a rapid result. So the advantage fibrinogen offers you over FFP is that it's a less of thawing time, there is a small volume needed, and you can do it fast. So this is a great advantage that it gives, and of course you can guide it with your thromboelastography readings. So I conclude here to say that you need early frequent monitoring, and this would be only possible with the help of point-of-care devices like HemoQ, your thromboelastography, and the new RTEG coming in. And of course, the fibrinogen levels, which can guide you into telling how severe your bleeding would be. I would not say it would tell you how, it would of course tell you how severe your bleeding is currently, but they can actually guide you to predict severity of bleeding and the efficacy of your therapies. And these would advocate an early use of FFP, fibrinogen, and platelets. The current concept of using fluid first, RBCs, and then thinking of FFP or a fibrinogen is actually fading away. You need to bring in these agents as early as possible so that the total amount that you're going to use ultimately at the end of the day are going to be reduced. We should encourage the use of FFP and RBCs in the ratio of 1:1, and there is a definite role of transfusion of fibrinogen and platelets. That's what I've been talking about. However, we really need a large multicenter randomized control trials to actually validify what all that is coming in the future. Thank you all for the patient hearing.